Welcome to the deep dive. Today we're tackling a really fascinating area, complex aortic surgery. Specifically, we're looking at the long-term effectiveness of using fenestrated endografts.
Right, for those really challenging aortic aneurysms, the ones right near the kidney arteries, juxtarenal, and also those extensive ones, the group FEV, the thoracoabdominal aneurysms, or TAAAs.
Yeah, exactly. These are aneurysms, in the main artery, the aorta,
Mm.
right, where critical branches supply the kidneys, the gut.
Vital organs,
Right.
and historically treating them a massive open
A
operation.
huge undertaking. For a long time, open surgery was really the only option. Then came these fenestrated endografts. A less invasive idea.
Definitely less invasive. You insert a custom-made stent graft through arteries in the groin, usually. And this graft has these little windows, fenestrations,
Precisely placed opening.
precisely placed, exactly, to line up with those essential branch arteries, keeping the blood flowing. It's pretty incredible technology.
It really is.
Yeah.
But, like with a lot of new medical tech, the initial results look good. But the big question mark was always.
The long run. How does it hold up over years?
Exactly. Which brings us to our source for today's deep dive. We're exploring a study called 12-Year Results of Fenestrated Endografts for Juxtarenal and Group 4 Thoracoabdominal Aneurysms.
Published back in 2015, Journal of Vascular Surgery, Mastracci et al. It gives us a really valuable window into, well, over a decade of experience.
And what makes it particularly interesting, I think, is where it came from. It's data from a physician-sponsored IDE, an investigational device exemption.
Started by the late Dr. Roy Greenberg, a real pioneer in this field.
Yeah. So it captures data from the very early days of using this tech, often in patients who were, frankly, considered too sick or anatomically unsuitable for the big open surgery.
High-risk patients, definitely.
So our mission today, unpack the key findings, understand how the tech itself changed over that time, and figure out what this tells us about using these grafts long-term.
Sounds good.
Okay, let's get into it. Where did this idea even start gaining traction, using fenestrated grafts for these complex cases?
Well, there was this growing realization, that while open surgery worked, it carried pretty significant risks, especially for older folks or people with lots of other health issues.
Comorbidities.
Exactly. So fenestrated endografts offered this potential alternative. Less invasive, delivered through smaller incisions, the idea of sealing the aneurysm while preserving flow to the gut and kidney arteries, it was very attractive.
But like you said early on, it was new. We didn't have that long-term data. So this study was really trying to fill that gap.
Precisely. The aim was to report on, survival over the long haul, complications, and crucially, how well those branch arteries, the visceral vessels, stayed open and functional over many years.
And the study design itself.
It was prospective, single center, so they followed a specific group of patients forward in time at one institution. That gives you pretty consistent data.
And not just any patients, consecutive patients treated for these specific aneurysm types, juxtarenal or group 5E, TAAA, using these grafts. And as we mentioned, many were high risk.
That's key context. High risk, either medically or anatomically. Some really didn't have other viable options.
So they were really pushing the envelope at the time.
They were, and the fact they collected data for 12 years is honestly quite remarkable. It gives you a depth you just don't get from shorter studies.
And it also reflects probably a learning curve, right? They mentioned 3 different surgeons were involved over that period.
Yeah, that's typical as techniques are refined and adopted. You see that learning process reflected in the data sometimes.
Okay, so after all that follow-up, 12 years of data collection, what were the big takeaways? How do these patients actually do long-term?
Well, the headline number for survival at 8 years was 20%.
20%. Okay, that sounds low on the surface.
It does, but you absolutely have to dig deeper. They did what's called a multivariate analysis, looking at multiple factors together.
To see what really impacted survival independently.
Exactly. And what they found was that things like getting older, having congestive heart failure, a history of cancer, even having had a previous aneurysm repair, these were all significantly linked to lower long-term survival.
So it really points towards those underlying health issues being major drivers.
It really does. And that's reinforced by another key finding. Death directly because of the aorta, an aneurysm rupture or related issue, was actually very low, only 2%.
Wow. Okay. So the grafts were doing their job in terms of preventing aneurysm-related death.
It strongly suggests that, yes. The patients had serious health problems limiting their lifespan, but the fenestrated grafts were largely successful in managing the aneurysm itself.
That's actually quite positive news for the procedure's effectiveness. What about specific complications? Something like spinal cord ischemia. That's always a concern with aortic procedures.
Right, SCI, a devastating complication. The rate here was reported as quite low, 1.2%.
Okay.
But interestingly, their analysis hinted, just hinted, mind you, that maybe covering the aorta more than about 5 centimeters above the celiac artery.
The artery supplying the stomach, liver, spleen.
Yeah, covering significantly above that might slightly increase the risk of a spinal cord event. The number of events was really small, so you can't draw firm conclusions.
But it flags something to watch.
It does. It raises a question about how much coverage is optimal and when maybe you need extra protective measures.
Interesting. Now, the devices themselves, the grafts with the fenestrations, they're complex pieces of engineering.
Yeah.
Did the design complexity affect outcomes?
That's a really key part of the story here, how things evolve. They found that, yes, more complex grafts, meaning more fenestrations for more arteries, tended to need more re-interventions later on.
More follow-up procedures.
Yeah. Specifically, if you had a fenestration for the celiac artery, there seemed to be a slightly higher chance of that artery narrowing or blocking over time.
Okay, that kind of makes sense. More moving parts, more potential issues. But what about the flip side? Simpler designs. Any downsides there?
There were. The study noted that simpler designs, maybe just fenestrations for the renal arteries, had a higher risk of something called a type I leak.
That's a leak at the top or bottom seal, right?
Yeah.
Between the graft and the aorta wall.
Exactly, and that's a significant issue you need to fix. So it was a bit of a balancing act.
And it sounds like the strategy for that balance changed over the 12 years. They mentioned a trend towards using more fenestrations for the same kind of aneurysm later on. Why?
The thinking seems to have shifted. The priority became getting a really secure seal at the top of the graft, the proximal seal, to prevent those serious type I endoleaks.
Even if it meant involving more arteries.
Even if it meant potentially incorporating more visceral vessels into the repair zone, the idea was extend the graft higher, get a better landing zone, even if that meant maybe a slightly higher risk of, say, a type 3 endoleak.
A leak between graft components.
Yes, or needing more branch vessel interventions down the line. Those were seen as perhaps more manageable issues compared to a persistent type I leak.
So a trade-off. Address the potentially bigger problem up front, even if it creates smaller, potentially fixable issues later.
That seems to be the logic that evolved. It highlights that classic thing with new tech, you start minimal, then realize maybe a bit more comprehensive is actually better long-term for the main goal.
And the technology itself, the hardware, wasn't standing still either, right? Big changes over 12 years.
Oh, absolutely. A huge one was moving from just basically holes cut in the fabric, unsported fenestrations, to using fenestrations reinforced with nitinol.
That shaped memory metal.
Yeah. That reinforcement made the connection point for the bridging stents much stronger, much more stable.
Bridging stents being the smaller stents going from the main graft into the branch arteries.
Correct. And that stronger connection allowed them to tackle more extensive aneurysms because it could handle the forces inside the aorta better.
That sounds like a game changer for stability. Any other big leaps?
Well, the bridging stents themselves changed too. They moved from bare metal stents to covered stent grafts, balloon expandable ones like JOMED, later ICAST. And crucially, this study actually showed that using these covered bridging stents led to better patency over time.
Meaning the branch arteries were more likely to stay open.
Exactly. And alongside the hardware, their understanding improved too. They refined how they used ultrasound, duplex scanning to check for narrowing in those renal arteries during follow-up.
So better tools and better ways to monitor patients.
Right. It all evolved together.
You mentioned those reinforced fenestrations also allowed treatment, even if the hole didn't line up perfectly with the artery opening.
Yes, that was important. The seal then relied more on the interaction between the bridging stent and the reinforced edge of the fenestration. You might think that's risky.
A potential leak point.
Potentially. But the study actually showed surprisingly low rates of major problems like stenosis, occlusion, or significant leaks at those connections. The reinforced design worked well.
Okay, so let's recap the treatment philosophy shift. Started out maybe more like standard EVAR, minimal aortic coverage.
Aiming for maybe a 15-millimeter seal zone, incorporating just the necessary vessels.
But then shifted towards covering more aorta, even if it meant fenestrations for more visceral arteries. Why that pivot?
Because the early experience showed that shorter coverage led to too many type I endoleaks. That proximal seal failure was the Achilles heel. And counterintuitively, perhaps, the initial worries about involving more branches.
Worries about those branches clotting off or having issues.
Yeah, those worries didn't really bear out in the long term. The branch vessel durability proved to be surprisingly good. Excellent, in fact.
So the trade-off made sense, except maybe a slightly higher chance of manageable type 3 leaks or branch interventions.
In exchange for drastically reducing the risk of the more dangerous type IA endoleak, that became the priority.
Got it. And back to that spinal cord ischemia risk, that 5-centimeter mark above the celiac artery. Even with small numbers, that seems like a practical point for surgeons to consider.
I think so. It's not definitive proof, obviously, given the small number of events in this study, but it strongly suggests that if your repair plan involves extensive coverage that high up, you might need to think about additional protective strategies like spinal drainage, especially in certain patients. It's certainly an area needing more research.
Okay. Now, despite all these changes evolving tech, shifting techniques, a learning curve over 12 years, the study reported a technical success rate of 97%. That's remarkable.
It really is, especially given the complexity. And perhaps even more importantly, the freedom from aneurysm-related death at 8 years was nearly 98%.
Almost 98%. So the procedure itself was extremely effective at preventing the aneurysm from causing death.
That's the clear message on that front, yes.
But, as we discussed earlier, the overall long-term survival wasn't nearly that high, around 20% at 8 years. And the study clearly points to the patient's other health problems.
Exactly. That multivariate analysis nailed it. Age, heart failure, cancer history, prior repairs, those were the factors driving overall mortality. It really highlights that fixing the aorta, while crucial, doesn't magically cure everything else the patient is dealing with.
So, pulling this all together, what are the big implications? How should we think about fenestrated endografts now, based on this long-term data?
Well, I think the study provides really strong evidence these grafts are a safe and crucially durable option for treating these complex aneurysms, specifically in terms of preventing aneurysm-related death.
Okay, safe and durable against the aneurysm itself.
Yes. And given that high technical success and the excellent aneurysm-specific outcomes, the authors reasonably suggest that maybe this technology could be safely used in a broader group of patients, perhaps some who are lower risk than the initial high-risk cohort in the IDE.
Expanding the indications, potentially.
Potentially. And getting more long-term data on those lower-risk groups would be really valuable to confirm that. We also have to be realistic. Reintervention rates are likely always going to be a bit higher with complex endovascular repairs compared to open surgery. That's pretty common across endovascular procedures.
A trade-off for the less invasive initial surgery.
Right. But when you weigh the lower upfront surgical risk, the excellent protection against rupture, and the good long-term branch artery function, it seems very likely these techniques will continue to replace open surgery for most patients whose anatomy is suitable.
Okay, so summing up our deep dive, fenestrated endografts have really proven themselves over the long term for these complex juxtarenal and group 4Phe TAAs. The tech evolved, understanding evolved,
Leading to excellent results in terms of preventing aneurysm rupture and maintaining blood flow to vital organs.
but the overall patient survival is often limited by their other health conditions, not the aortic repair itself.
That seems to be the clear picture from this 12-year look back. The procedure works very well for the aorta. Managing the whole patient remains the broader challenge.
That's a fantastic summary. And it does make you think. Considering these findings, especially how well the grafts protected against aneurysm death, even in sick patients, what's the next step for improving overall long-term outcomes? If the aortic repair is largely successful.
Where do you focus next?
Exactly. Maybe the next frontier isn't just refining the aortic device, but really doubling down on aggressive management of those comorbidities. The heart failure, the other issues that seem to be limiting lifespan. Could that be the key?
That's a really insightful point. Moving beyond just the plumbing fix to more holistic, long-term patient management. It certainly seems like a critical area for future focus.
Something for us all to think about. Well, thank you for taking this deep dive with us today. Really informative.
My pleasure. It's fascinating work.
Until next time.